Hello everyone, it's my pleasure and great honor to share with you this very important lecture about types and the pathophysiology of cardiac amyloidosis. Amyloidosis are a group of systemic diseases characterized by organ deposition of misfolded protein fragments of diverse origin. The natural history of the disease, involvement of the other organ, and the treatment options vary significantly based on the protein of origin. While there are over 27 known proteins that can aggregate as amyloid and defined histologically by staining with Congo red stain, nearly all cases of cardiac amyloidosis result from only two protein precursors, either light chain or transthyretin. Accordingly, more than 98% of the currently diagnosed cardiac amyloidosis results from fibril composed of monoclonal immunoglobulin light chain in the AL or primary type, or transthyretin either in its hereditary or familial form or acquired or senile form. Although considered a rare disease, recent data suggests that cardiac amyloidosis is underappreciated as a cause of common cardiac diseases or syndromes. Recent advances in cardiac imaging, diagnostic strategies, and therapies have improved the recognition and the treatment of cardiac amyloidosis. So, what is the etiology according to the type? In primary or AL amyloidosis, it is caused by deposition of amyloid light chain, most commonly due to plasma cell dyscrasia. It is also called monoclonal gammopathies or paraproteinemia, such as multiple myeloma. While in the secondary amyloidosis or AA type, it is caused by deposition of amyloid A protein in chronic inflammatory conditions such as rheumatoid arthritis. The third type, which is the familial or hereditary amyloidosis, it is due to inherited mutation in the transthyretin gene with deposition of mutated type of transthyretin, and it is characterized by autosomal dominant inheritance pattern, rendering a 50% chance of passage to the offspring. The last type is the senile systemic amyloidosis, and it is caused by deposition of wild type of transthyretin with striking male predominance. What is the transthyretin protein? It is a protein produced by the liver, formerly known as prealbumin, and its function is to transport the thyroid hormone and vitamin A. What are the affected organs according to the type? In primary amyloidosis, the affected organ include kidney and present as nephrotic syndrome, heart and present as heart failure, restrictive cardiomyopathy, GIT, and soft tissue. In secondary amyloidosis, it can involve the heart. Familial amyloidosis has cardiac involvement and it is called familial amyloid cardiomyopathy, as well as peripheral and autonomic nervous system involvement, and it is called familial amyloid polyneuropathy. And in senile systemic amyloidosis, it involves mainly the heart, with reported cases of bilateral carpal tunnel syndrome, spinal stenosis, and biceps tendon rupture. What is the pathophysiology? According to the site of infiltration, let's start with ventricular walls infiltration. The consequences include increased biventricular wall thickness, LV and RV, with ventricular stiffness, which are the hallmarks of restrictive cardiomyopathy. And let's go for the atrial infiltration, which result in high prevalence of atrial fibrillation and electromechanical dissociation, with increased risk of atrial thrombus formation due to significant left atrial dysfunction, increasing the risk of thromboembolism even in sinus rhythm. And finally, infiltration of the small arterioles of the heart, which results in angina or myocardial infarction in some cases, with coronary flow reserve abnormalities in PET scan due to microvascular amyloid infiltration. What is the mechanism of cardiac dysfunction in AL amyloidosis? The mechanism include interstitial infiltration, direct light chain toxicity. Free light chain can promote lysosomal dysfunction, which leads to generation of reactive oxygen species and eventually cell death or apoptosis. Additional important notes about systemic amyloidosis. About 10% of patients with multiple myeloma may have AL amyloidosis. About 10% of AL amyloidosis patients may have multiple myeloma. 50 to 70% of AL amyloidosis patients have some degree of cardiac involvement, and it is the most important determinant of survival in these patients. Patients with untreated AL cardiac amyloidosis and congestive heart failure have an overall median survival of only 6 months, and recent advances in survival have been made in AL amyloidosis with advances in the treatment strategies extending the median survival up to 5 years or longer. What about transthyretin amyloidosis? The prevalence of senile amyloidosis increases with age. Up to 25% of patients over the age of 80 have demonstrable amyloid deposition by histopathology. Recent studies that suggest that senile amyloidosis may account for up to 10% of elderly patients with heart failure, while the familial type is commonly associated with peripheral neuropathy. The senile type has mainly cardiac affection. Thank you so much.